Hello, it's Miss Markham, and welcome to Musculoskeletal Part 3, the final chapter. Let's start with something nice and simple, shoulder impingement. Primary, that is when there is a mechanical narrowing of the space, versus secondary, which would be caused by repetitive overuse, trauma, and body mechanics. An internal posterior is common with overhead throwing athletes. It occurs with 90 degrees abduction, abduction, and full lateral rotation. A rotator cuff tear is when the tendon will pull away from the bone, which usually occurs with the supraspinatus. What are the rotator cuff muscles? Supraspinatus, infraspinatus, subscapularis, and teres minor. Shoulder impingement primary. As mentioned, it is because of a mechanical narrowing of the space. Primary impingement usually occurs with older populations, those of us who are 40 and above, and it is caused by degenerative changes to the rotator cuff, the acromion process, the coracoid process, and the soft tissues. It is insidious, which means it is gradually harmful. Over time, stress overload will result in impingement. Primary impingement can also be caused by the shape of the acromion. This could be genetic. A surgeon would come in and alter that space that is available for the soft tissue to glide smoothly through. So when we're talking about the supraspinatus, that area is called the supraspinatus outlet. Take a look at the image. The supraspinatus outlet is the space formed by the acromion, the coracoacromial arch, and the acromioclavicular joint. These three structures form the upper rim, and the humeral head and the glenoid would be on the lower rim. It accommodates the passage of the supraspinatus tendon. If that passage is narrowed, the tendon will take a beating. Secondary impingement commonly presents with instability of the shoulder complex, especially with our throwing athletes. Hypermobility does not imply instability, it only implies that there is more looseness or more range of motion. Instability implies that the patient is unable to control or stabilize a joint during motion or with a static posture or position. This is usually because of injury, such as the tearing of the capsule or the labrum. Because the muscles controlling the joint are weak, or the force couples are unbalanced, a force couple is a group of muscles that will work together in a synergistic manner. If the muscles and the ligaments are unable to provide stability, there will be slippage, there will be instability. The internal or posterior shoulder impingement is an example of a secondary impingement. This is common with our overhead throwing athletes. As stated, as you can see in the picture, at least 90 degrees abduction and full lateral rotation will cause the impingement. This causes repetitive contact between the posterior aspect of the greater tuberosity of the humeral head and the posterior border of the glenoid fossa. The rotator cuff. A rotator cuff can be torn because of trauma or because of chronic degenerative pathologies like chronic impingement. It is more common in patients who are 50 years and older, basically because of that chronic degenerative pathology. It is classified as a partial thickness when it extends only through a portion of the tendon, or a full thickness, which is a complete tear of the tendon. The size of the tendon can be small, 1 centimeter or less, to large, more than 5 centimeters. In many cases, the torn tendons have begun to fray, just like a rope that was kind of overused, just the little fibers fraying. As the damage progresses, the tendon can completely tear, and sometimes that will occur when lifting a heavy object. There are different types of tears. We've already discussed partial and full. An acute tear occurs with injury. For example, falling down on an outstretched arm or lifting something too heavy with a jerking motion. This type of tear can occur with other shoulder injuries as well, such as a broken collarbone or a dislocated shoulder. A degenerative tear is the most common. Most tears are a result of wearing the tendon down. This occurs slowly and naturally with age, starting around 40. They are also more common in the dominant arm. There are several factors that contribute to degenerative or chronic rotator cuff tears. Repetitive stress. Repeating the same shoulder motion again and again can stress your rotator cuff muscles and tendons. Baseball, tennis, rowing, lifting, these are all examples of sports activities that can put you at risk for overuse of the tendon and result in a tear. Many jobs and routine chores can also cause these types of tears as well. Raking, shoveling, painting. Lack of blood supply. As we get older, our blood supply in our rotator cuff tendons will lessen. Remember, tendons become less pliable with age. They lose water. They lose blood supply. Without a good blood supply, the body's natural ability to repair the tendon after it's damaged will be impaired. This could ultimately lead to a tendon tear. Bone spurs. As we age, we get bone spurs. That's bone overgrowth. They often develop on the underside of the acromial bone. When lifting our arms, the spur will rub into the rotator cuff tendon. And over time, it will weaken the tendon and make it more likely to tear. Let's try to put it all together. Etiology. Intrinsic factors associated with rotator cuff tears include impaired blood supply to the tendon and degeneration. Extrinsic factors include trauma, repetitive microtrauma, and postural abnormalities. Symptoms. These patients will have pain at rest and at night, particularly if lying on the affected shoulder. There will be pain when lifting the arm or with specific movements. Weakness can also be present when lifting or rotating the arm. Crepitus, that sensation, will move into the shoulder in certain positions. When the arm is positioned in internal rotation and adduction, ADD, there will be point tenderness at the greater tubercle and the acromion. The patient will present with marked limitations in shoulder flexion and abduction, abduction, with the upper trapeze recruitment is evident. What does that mean? Upper trapeze recruitment is evident? It means you'll see them kind of lifting their shoulder. They're using their trapezius muscles to compensate so that they don't have to just rotate at the arm in that shoulder joint. And what's the action of the upper trapezius? It's upward rotation and elevation of the scapula. Treatment will start with conservative management, which will include rice and NSAIDs. Our primary focus with therapy would be to try to prevent adhesive capsulitis and to strengthen the upper extremity musculature. Surgical management can be used to repair, and it can be arthroscopic, mini-open, or a fully open approach. Following surgery, the patient would be immobilized in a sling. That amount of time will vary depending on the surgeon's preference, surgical procedure, and the size of the tear. A large tear may require 4 to 6 weeks of immobilization. To return to activities that involve dynamic overhead motion, that could take as long as 9 to 12 months. When one or more of the rotator cuff tendons is torn, the tendon no longer fully attaches to the head of the humerus. And again, most tears occur in the supraspinatus muscle and tendon, but other parts of the rotator cuff can also be involved. Let's jump down to the lower body and talk about limb length discrepancy. You'll also hear it called leg length discrepancy, LLD. You will learn how to use a tape measure in Rehab 1 to measure from the ASIS to the medial malleolus. It is important that the therapist flex the knees to the chest first to align the pelvis. This slide gives a variety of possible causes. Like other conditions, sometimes surgery is warranted, sometimes it is not. So if the leg length discrepancy is 2 centimeters or less, there's no treatment and no intervention. It's considered benign. If it is between 2 and 4 centimeters, the patient would be prescribed a special shoe insert. If it is greater than that, then surgery may be warranted. Epiphysiodesis is a procedure that is used to stop or slow the growth of the longer leg and to allow the shorter one to catch up. The doctor will calculate what the discrepancy will be when the legs are done growing. It's a little bit of guesswork here. The procedure will stop the long leg from growing when the short leg has about that much left to grow. Surgical lengthening is different. It uses the body's own capacity to create new bone. They would place an external fixator that would slowly pull the bone 1 millimeter a day. It is extremely painful and not always worth the gains. The patient may or may not be even able to weight bear during the process. When the limb is greater than 20 centimeters difference, an amputation may be used, and then the patient would be fitted with a prosthesis. Apparent or functional. This will have unilateral asymmetry without the shortening of the osseous component of the bone. So this would be caused by something such as shortening of soft tissues, joint contractures, loose ligaments. The axial skeleton could be all wampa-jaw and not correctly aligned. Or the biomechanics of the foot. For example, somebody walks with excessive foot pronation. This is how functional LLD or apparent LLD varies from the structural LLD we just talked about. Think about what would happen if one leg was longer than the other. There would be terrible posture, and your balance could really suffer, as well as your ability to engage in activities such as running and playing sports. I briefly touched on a hemiarthroplasty in the last lecture. It's also known as a partial hip replacement. This still has 2 components. There is a larger femoral head and a smaller femoral head with a stem that would fit inside it. This produces less friction, and so there becomes less wear on the joint surface. This procedure is rarely used for arthritis because there must be a normal acetabular surface. A hemiarthroplasty can be converted later if the degeneration continues. Like any joint replacement, the fixation can be cemented or non-cemented. In either case, we would educate the patient to avoid rotational forces so as not to loosen those components. Hip labrum tear. I'm pretty sure I have one of these, but I haven't gotten the MRI yet. So let's talk about the mechanism of injury. Trauma, right up there, and it's usually caused by repetitive trauma to the hip joint with demands like twisting, cutting, which is when you do those sharp changes in direction when running, and compression forces. I damaged mine as a dancer. Tissues involved are the labrum. The labrum is a band of fibrocartilage that surrounds the hip joint. There's also a labrum in the shoulder. Let's just keep it simple and talk about the hip joint right now. The labrum is significant as a weight-bearing structure. It acts like a rubber seal to help hold the femoral head securely within your hip socket. Once torn, the labral tissue in the hip doesn't have the ability to heal on its own. The labrum will not heal on its own. Labral resection or partial removal can be progressed quicker than a labral repair, just like with the meniscus. It will slow the healing process, but in the long run, it is better for the individual. Signs and symptoms, and I can attest to these, is a deep ache in the front of the hip or the groin. There can be a painful clicking or catching with some hip movements. The pain will increase with prolonged sitting or walking. I just can't win. And there can be a sharp pain in the hip or the groin when squatting. This eventually leads to weakness in the muscles that surround the hip joint and stiffness in the hip. In some cases, the surgeon may also find it necessary to perform an osteotomy to further protect the labrum and to help prevent re-injury. Now let's talk about the shoulder, and we'll use a SLAP tear. SLAP stands for superior labrum anterior and posterior. The superior part of the labrum is injured. That is where the bicep tendon attaches to the labrum. A SLAP tear occurs both in front, anterior, and back, posterior of the attachment point. That's of the bicep tendon. The bicep tendon can be involved in the injury as well. During a SLAP repair, the surgeon will reattach the labrum to the glenoid, and there could be, and that's stated, if there's separation of that tendon, then they will also reattach the tendon of the bicep muscle to the labrum as well. The healing time is the same for tendons, so we're looking at 12 to 16 weeks, and of course we're always going to use the MD protocol. We have some precautions and contraindications. There would be no biceps brachii contraction for around 4 weeks. We would want to avoid increased stresses to that anterior tissue, and we do that by avoiding shoulder extension and external rotation. The patient should not lift anything greater than 2 pounds with that involved arm, and that means they also cannot support their body weight on that arm through their hands. No sudden jerking motions, and no excessive behind the back movements. Shoulder arthroplasty. Sometimes shoulders need replacing too. There are several reasons why this surgery may be indicated. For example, a 4-part fracture of the humeral head. So that's severe damage that they can't rebuild. So they'll just have to replace the humeral head. And just like within the femur, there could also be avascular necrosis. If that happens to the humeral head, it will also need to be replaced. That can be caused due to chronic steroid use or deep sea diving, severe fracture of the shoulder, sickle cell disease, or heavy alcohol use can all result in avascular necrosis of the humeral head. And at this point, it should go without saying that osteoarthritis and rheumatoid arthritis are other reasons why someone may need a shoulder replacement. Much like the hip replacement, you can see in the top image that you have a ball and socket that goes into the humerus, and then there will be the glenoid surface will be covered with another component. Occasionally, a shoulder replacement needs to become a reverse total shoulder replacement. I've seen one of these in my career. During a reverse arthroplasty, the humeral component is placed in the glenoid socket, and the glenoid component is placed on the proximal humerus. When this is done, to power and position the arm, the person will now be relying on the deltoid muscle opposed to the rotator cuff muscles. No matter which population you work with, you will encounter musculoskeletal issues. This term is more inclusive than orthopedic. You can't have one without the other. Musculoskeletal issues come with orthopedic conditions. Consider how a musculoskeletal tissue contributes to our overall health, well-being, and function. 28.6 million Americans incur musculoskeletal injuries per year. Humans are living longer and longer, and with age, we will develop more opportunities for musculoskeletal injuries, especially those bony conditions that may need treatment. Some conditions are systemic, but even the local ones will significantly affect other body systems around them, so we always need to look at the whole patient. Let's talk about a condition that many of you have already heard of, scoliosis. Scoliosis is an abnormal lateral curvature of the spine. In general, when the curve is less than 20 degrees, it will rarely cause any significant concerns, but curves that have greater than 60 degrees can compromise lung function and cause significant issues with back pain, disc disease, vertical subluxation, and sciatica. Curves are designated right or left based on the convexity. For example, a right thoracic scoliosis describes a curve in the spine with a convexity to the right. But to the left would be more common with lumbar curves. The right is more common with thoracic curves. There is potential for associated rib cage deformity and other spinal deformities such as kyphosis and lordosis. Additionally, rotation of the spine could also be present, but it's not always present. The etiology of scoliosis. Scoliosis can be classified in a few ways. 80% of the cases are idiopathic, while osteopathic is a result of spinal diseases or bony abnormalities. Myopathic is a result of muscular weakness, and neuropathic is a result of central nervous system disorders. The age of onset determines the subset classification. 0 to 3 years old can rapidly progress due to the altered development in utero. Juvenile is between 4 years in puberty. Adolescent scoliosis is 12 years old for girls and 14-year-old for boys. And adult is after their skeletal maturation is completed. So that age can vary depending on when the individual skeleton has fully matured. The curvature can be an S curve or a C curve. Usually there is one primary curvature with a secondary or a compensatory curvature that will develop to balance out the body. In some cases, there can be two primary curves as well. Convexity to the right is associated with juvenile scoliosis. Neuropathic and muscular is due to imbalances or asymmetry of muscle activity through the trunk and the spine. This can often be because of a developmental pathology, which would result in alterations within the structure of the spine. The incidence of scoliosis is higher for certain populations that have neuromuscular disorders like cerebral palsy and muscular dystrophy, so neuropathic disorders. Structural cannot be corrected with movement. Again, it cannot be corrected with movement. It can be congenital, musculoskeletal, neuromuscular, or inherited. Non-structural is known as functional or postural scoliosis. This is a reversible curve that can change with repositioning using passive movement or active lateral bending towards the apex. This can primarily be caused by LLD, limb length discrepancy, but it can also be from other factors such as pain or even poor posture. The curve would disappear when the cause is removed, but if it's not treated, it can become structural. Now let me put all these terms together in a way that scoliosis might be defined. If I say that my patient has adolescent, non-structural, myopathic scoliosis, what am I saying? I'm saying the scoliosis is due to muscular weakness and the onset was between puberty and their skeletal maturation. And I'm saying it's possible for PT to help up until it's reclassified as structural if it goes untreated. Prevention. Prevention requires early detection, which is why we all get tested throughout our adolescence. Bracing is a passive restraint system with the goal to maintain the curvature within 5 degrees of the original measurement. It has a good success rate, Approximately 85% of these patients will meet that goal. The braces are donned, but they do not correct the curve. They only try to keep it maintained within 5 degrees of its discovery. The goal is to prevent it from worsening. When the curvature is greater than 40 to 45 degrees, they may require surgery, especially because of chronic pain and the neurological changes. The surgeon would place Harrington rods with a posterior fusion, but no more growth could be possible after this. So what if the child is still small? We would have to use braces. Let's take a look at the next slide at some of these braces. The Milwaukee, or CTLSO, is for those at T8 and above. The Boston is known as a TLSO, and those are for patients that have their curvature lower than T9 or 10. The Lion brace is used for idiopathic scoliosis with hypokyphosis, and the Charleston attempts to minimize that side bending. The most common type of brace is made of plastic, and it's contoured to conform to the body. The brace is almost invisible under clothes. They fit under the arms and around the rib cage, lower back, and hips. Most braces are worn day and night. A brace's effectiveness increases with the number of hours a day it's worn. Children who wear braces can usually participate in most activities, and they will have few restrictions. If necessary, the kids can take off the brace to participate in sports or other physical activities. The braces are discontinued after the bones stop growing. Scoliosis problems. Asymmetric shoulders and asymmetric pelvic positioning will cause compensations that can affect all the way down the kinetic chain and impact other areas of the body. It can lead to LLD and deformity. Look at the image on the slide and try to twist yourself into this position without hurting yourself. Now, take a breath. Do you think this posture has an effect on the respiratory system? It absolutely does. An adult with scoliosis may have back pain from muscle fatigue, trunk imbalances, spinal stenosis, degenerative disc disease, and they can have radiating lower extremity pain, also called radiculopathy. Physical interventions will include us observing and correcting posture and body mechanics. We are going to need to strengthen the back extensors, the abdominal wall, and possibly the pelvic and neck musculatures as well. Stretching would be useful in the hip flexors, hamstrings, and quadriceps, and of course they will need their own home exercise plan. Diagnosing scoliosis. Cobb's method is used for measuring scoliosis using a standing radiograph, and it is quantifiable. You can go check out the YouTube video I have provided for you in the course content folder. The forward bend test. This is one we are all familiar with from school. This is a method that screens for scoliosis. Any suspicion, and the child should be referred to an orthopedist for x-rays. The process goes like this. The child bends forward with their arms hanging in front and the knees straight. The therapist stands behind and then in front of the child to assess for back symmetry. Asymmetry may be noticed by one side of the back being more prominent than the other, or the spine appears curved when viewed from top to bottom due to rotational deformity on the convex side, which is observed as a rib hump. It's sometimes seen in the upright position, but it is always apparent in the forward bend position. Duchenne muscular dystrophy. DMD is a progressive neuromuscular degenerative disorder that manifests once fat and connective tissue begin to replace muscle that has been destroyed by the disease process. So again, muscle tissue will be replaced by fat and connective tissue. It is the most common fatal genetic disorder diagnosed in childhood. It affects nearly 1 in every 3,500 live male births. It is X gene recessive, which means it only presents in males, but it can be carried by females. The lack of dystrophin allows damage to occur to the sarcolemma with muscle contraction. There is a variable rate of the reduction of these contractile units, and diagnosis will usually occur between the ages of 2 and 5 years old. There are several types of muscular dystrophy, but we are only going to talk about Duchenne's. Duchenne's is a loss of dystrophin, 2/3 of which are inherited, and 1/3 is a new mutation. What is dystrophin? Dystrophin is part of a protein complex that is important to stabilize the muscle cell membrane, or the sarcolemma. Without it, the sarcolemma essentially wilts and becomes unstable over time. Cellular proteins start to escape the muscle cells, and calcium starts to enter the cells, which ultimately leads to cell death. Initially, there is regeneration, but the muscles cannot keep up. This is different than other disease processes that cause weakness because of damage to a nerve. The dystrophin protein is present in the heart muscles and the diaphragm as well, so this can lead to dilated cardiomyopathy, arrhythmias, and respiratory failure. Death usually results from heart or respiratory failure. 1/3 of DMD patients will have a learning disability as well due to dystrophin abnormalities. This is a progressive disorder that causes general weakness due to fat and connective tissue replacing muscle. The ability to walk is usually lost between the ages of 10 and 12. The pathogenesis starts with lower extremity and then upper extremity involvement as it progresses into the teen years. Over time, they will experience activity limitations and participation restrictions. They will decline and develop difficulty with transfers and other activities of daily living. Symptoms usually occur by the age of 5 at the latest. So what are some of these signs and symptoms? Gower's sign is usually the first indication. That is when the child is trying to transition from sitting to standing. They will begin walking their hands up the thighs to assist in that position change. There is also pseudohypertrophy. So the calf muscles are going to atrophy. The muscles themselves are slowly disappearing. But because the muscle is being infiltrated by that fat and fibrotic tissue, they seem to be really large. This primarily occurs in the calf muscles. You can see an example here on this slide. DMD leads to many complications. Disuse will lead to many problems: atrophy, contractures, scoliosis, weight gain, deformity, GI problems, and as I mentioned, cardiac and respiratory dysfunction. These are the most common complications. These patients may also experience pain. Besides just the difficulty of breathing, the weakness with taking breaths, that will also result in a weak cough. And a weak cough leads to increased infections. Joint contractures may also develop, and this will limit the joint movement. Decreased demands on the muscles will result in limited joint motion. The doctor will prescribe glucocorticoids. In 2016, the FDA approved this drug, eteplirsen. I'm pronouncing that the best I can because I can't find a way to pronounce it online. But anyway, there was an original study in 2016 that found that it produced a dystrophin. But in 2019, more research discovered that it only targets specific mutations, which makes it useful in just 1% of the cases. And a year's worth of this treatment is expected to cost $300,000. Immunosuppressants may also be prescribed by the doctor. PT management of DMD. PT will focus on maintaining strength, encouraging mobility, adapt to loss of function, family education, and their involvement in a home program. Manual muscle testing and range of motion should be evaluated consistently. Why? We need to track the progression of the disease. We will recommend orthotics, adaptive devices, wheelchairs, and as the disease progresses, our focus may shift to preventing contractures, teaching patient positioning, pain management, breathing exercises, and postural drainage, which you'll learn in rehab too. Mechanical stretches should be avoided. There's some controversy over strengthening, because that's what we do, right? We like to strengthen people. Well, not in this case. Some studies say no eccentric strengthening because it is the primary culprit for DOMS, which causes muscle damage. When the muscle is damaged, it forces the muscle to try to repair itself. Normally, that will make the muscles grow back bigger and denser, but with DMD, the muscle will not repair itself. All studies agree submaximal strengthening is safest with no fatigue. What does submaximal strengthening mean? You'll get a better idea of that in Rehab 1, but basically it means they should have zero fatigue from their workout. The PT can help improve their quality of life, but they will never reverse the underlying process. I have included a video in the course content on the pathogenesis of this disease. Notice that I have told you in that write-up to stop watching at 5 minutes and 32 seconds. You're welcome to watch the rest of the video, but it does not apply to this class. Do not take notes on it. It is not important for you to keep watching the video. Spinal muscular atrophy. It is a progressive neuromuscular disease characterized by progressive weakness and wasting of skeletal muscles because of an anterior horn cell degeneration. This is the second most fatal autosomal recessive disorder after cystic fibrosis. Notice the commonality, progressive weakness and wasting of skeletal muscles. But what's the difference here? It is because of an anterior horn cell degeneration. It is neuromuscular. It is not genetic. We will discuss this disease in Pathology 1, even though it's technically a neuromuscular disease, because it does fall under the muscular dystrophy umbrella. It is autonomic recessive, which means the parents of an individual with an autosomal recessive condition, each one of those parents carry the mutated gene, but they won't typically show signs and symptoms of the conditions themselves. The person needs 2 copies of this gene. This gene mutation results in a shortening of the SMN protein, and that's needed to make motor cells. This gene is normally inactive during the fetal period, and so the individual will grow normally. It allows for normal apoptosis in the developmental fetus. Apoptosis is genetically directed cell destruction. Without it, cells may grow out of control and tumors can form. Spinal muscular atrophy is a lower motor neuron disease, a progressive degeneration of alpha motor neurons, aka the anterior horn cells. The posterior horn cells are spared. That means sensation is intact. These patients may also see other central nervous system involvement. Here we have the different types. Type 1 is the most severe and it'll cause respiratory failure and death within the first few years of life. Type 2 is considered intermediate. The patient will be able to sit independently, but they will lack functional independence and mobility. Type 3 is mild. These patients can usually walk with an assisted device with a slow progression of the disease. There is also a type 4, which is adult onset. Now, even though these are divided into different types, it's a continuous spectrum of severity. There is no current effective curative treatment. SMA is the most common genetic cause of infant death. Wait, didn't I just say that about DMD? No, that is the most common cause of childhood death. The prognosis is not good. Death occurs because of respiratory compromise. The younger the patient is at the onset, the worse the prognosis. Other complications would be spinal deformity or scoliosis, and the respiratory issues are similar to DMD. They'll need cough assistance, maybe a BiPAP, ventilator support, and the signs and symptoms will also be atrophy, weakness, and fatigue. PT management. We will begin with active movement to maintain joint movement. Some studies and some theories recommend that PT do not strengthen this patient population as it can speed up degeneration. Hand splints. These are custom made and usually worn at night to keep the wrist and fingers in a good position to help prevent contractures. Treatment for this patient type is typically symptomatic and preventative for these orthopedic issues such as scoliosis. In the event of scoliosis, it may be managed with a spinal fusion. Torticollis. Torticollis means twisted neck. It's a disease, but it's also a symptom of other conditions. Acquired torticollis. Acquired means it's not actually torticollis. It's actually called cervical dystonia. This can be a result of position or it can be caused by trauma. It can even result from other pathologies like an upper respiratory tract infection. True torticollis is called congenital torticollis, and the most common cause is birth trauma or malpositioning in utero. This can lead to abnormal development of the hip or hip dysplasia. It is present in about 1 out of every 5 infants with the congenital torticollis condition. Why do you think that is? Well, if their head is to the side, which basically they're going to laterally flex and rotate downward, this is going to affect their sitting. They're not going to have even weight bearing in their hips as they develop, so that tummy time and sitting will all be thrown off by the weight of their head. The preference is to use non-operative measures like physical therapy, and this can take 12 months to 24 months before surgery is even considered. The PT treatment will include stretching at least 3 times daily for 3 to 6 months, massage, heat, TENS unit, sensory feedback, active range of motion, strengthening, proper positioning when static, sleeping and feeding, as well as dynamic play. The therapist will use tummy time, car seats, stability balls, and carrying positions to help. I have included a link for a non-YouTube video for you to meet Jonathan, a child with torticollis. Arthrogryposis. This is a non-progressive condition characterized by multiple congenital joint contractures found throughout the body at birth, aka MCC, multiple congenital contractures. The contractures themselves are not progressive, but the extent of the disability can be significant. As the child develops and changes, so will their disability. It's considered idiopathic. However, there is an underlying theme of decreased fetal movement in utero. Factors for MCC are abnormalities of the muscles. This is because of central nervous system involvement. There could be lower motor neuron involvements, that's your anterior horn cells, the fetal environment, and in some cases there seems to be a recessive genetic link. Arthrogryposis is also known as fetal akinesia, which means decreased fetal movements. due to these fetal abnormalities with some underlying cause. Maternal disorders. They may also be an underlying condition, for example, infection, drugs, trauma, or maternal illnesses. During early embryogenesis, joint development is almost always normal. Motion is essential, though, for that normal development of their joints and the structures around them. This results, when they don't have this normal movement in utero, this will result in fixation of the joint, which will limit the movement and further aggravate the joint contracture. Contractures are secondary to fetal akinesia. The condition will be more severe the earlier it is diagnosed. On average, it is diagnosed between 16 and 18 weeks of gestation. Arthrogryposis impairments. The typical ones are joint contractures, articular rigidity, weakness, and in some cases, the muscle is replaced with fibrous and fatty tissue. These children have completely normal minds, and so they often discover compensatory movements as they grow on their own. And as adults, they will tend to develop arthritis. They will also benefit from a wheelchair for long-distance mobilization to save their joints and to save their energy, as it takes more energy for them to be mobile than someone without joint contractures. Our goal will be to optimize their quality of life. This includes communication capabilities, such as getting someone to assist them with their daily activities. They should feel empowered to be able to communicate their needs. We also want to make sure that they have some capacity for social participation, independent ambulation whenever possible, and hopefully independent living. The early PT will be focused on gaining head control and trunk control. We're talking infantile early PT. There will also be range of motion and stretching exercises. These are the cornerstone of PT for these children. Range of motion and stretching exercises. Family compliance with the exercise plan is crucial. We should look at ways to incorporate these activities into their daily routine, such as changing diapers, dressing, bathing time, etc., so it is easier on the family. Once these children are school age, they should start to take charge of their own routine. They need to be educated on joint preservation and energy conservation so they can become more independent as they grow into adulthood. Arthrogryposis function. Well, there is no cookie-cutter therapy for these children. Range of severity varies greatly. The therapist must accommodate for the deformity that is present and with the ability of each individual child. So the infant-child goals will be to maximize strength, increase range of motion, enhance sensory and motor development. These strategies will include teaching rolling, scooting, again, stretch, strengthen, position. We need to address the challenges of their activities of daily living and begin gait training. Medical surgery side, they may benefit from club surgery if needed. Splints can also be used and adjusted every 4 to 6 weeks. They will need a stroller for the community, and then other surgeries might be needed as they grow. The exercise plan, to reiterate, will be 3 to 5 times daily. They will need to be standing for 2 hours a day, and they can use a parapodium for that. Later, we want them to be in playgroups, get involved in sleepovers and sports. In adolescence, the goal will be to strengthen their peer relationships and give them independent mobility and preserve their available range of motion. So these strategies will involve adaptive equipment, environmental adaptations, stretching, and compensatory ADLs, teaching them new ways to do their activities of daily living. And with the med-surg side, we're going to be looking at a wheelchair, and they may need more surgeries. For their exercise plan, we want to get these kids into sports, social activities, have them doing self-directed stretching and prone positioning. Surgery. As I mentioned earlier, they might get clubfoot surgery, and they could need corrective surgery for any severely affected joint and limb. The Ilzarov method is a proven technique for correcting limb deformity. A frame is attached to the outside of the limb using pins and wires. Over time, the shape of the limb is gradually adjusted until the leg is corrected. Another similar technique involves spatial frames. These are utilized similarly to the Ilzarov method. So what's the prognosis? PT and OT are the mainstays of early treatment. Prognosis will depend on the severity. The contractures themselves are not life-threatening and they are not progressive, but the underlying cause that brought it on may be. Osteomyelitis. Inflammation of the bone caused by an infection. This can be bacterial, fungal, parasite, and viral. It can be classified as acute, new, or chronic, which occurs with relapses, persistent infection, or the acute disease remained undiagnosed. Acute is less common and often occurs in children. Chronic osteomyelitis is more common in adults and the immunocompromised. Osteomyelitis is becoming more common due to drug-resistant organisms, IV drug users, and use of implantable prosthetic devices. Several different bacteria are usually responsible, but staph is the most typical. It is acquired one of two ways: exogenous, which means it was acquired from the outside, damage to the bone, maybe from a surgical procedure, a compound fracture, or a puncture wound that penetrates the bone, may directly expose the bone to infectious microbes. Hematogenous is acquired from another infection. The pathogenesis here is poorly understood, but it usually involves an inflammatory response. Proliferation of the infection forms a subperiosteal abscess, inevitably depriving the bone of blood supply, which could lead to necrosis. It is difficult to detect initially because it may not be painful, as there are no sensory endings in the calcaneus bone. The infected bone is predisposed to pathological fractures at that point. There are some signs and symptoms, but they differ in adults and then in children. For adults, the first symptom is usually low back pain, but once the infection is systemic, they will develop a fever. Children, on the other hand, tend to experience severe pain, fever, and even edema in the area. The pain is often described as deep and constant. Prevention would be to recognize it as a complication of open fractures, understanding that proper wound care is crucial, and antibiotics are now used for these high-risk procedures such as dental work or other procedures that pierce the skin. A bone biopsy is the most conclusive procedure for diagnosing and determining the specific infectious microbe that's present. The risk of this disease increases with other diagnoses such as diabetes, sickle cell, elderly, or immune insufficiency. Treatment begins immediately with high-dose antibiotics, and the prognosis is good if it's acute. Surgery would be indicated if it's spread to the joints. That is considered an emergency situation because there is an increased risk of amputation if it becomes chronic. Typically, 90% of the acute infections are stopped when immediate treatment is given, but going as few as 7 to 10 days without treatment could cause permanent loss of bone. Discitis. In children, the origin may be traumatic or spread through bacterial infection through the bloodstream, like an upper respiratory infection. Upper respiratory infection. In adults, the disc has virtually no vascular supply, which makes it difficult to fight off the infection. Adults usually acquire discitis post a discectomy surgery. What is discitis? It's a spinal infection. And that infection may spread to adjacent vertebra through cartilaginous end plates. The clinical manifestations are fever and disc pain in children. They may also lose weight, refuse to walk, and report pain with hip extension. In adults, it will be made worse with activity that doesn't get better with rest. So, made worse by activity, but rest doesn't make it go away. Diagnosis is done with an X-ray and a follow-up MRI, and then, of course, bone scans may also be used. They can enhance what they're seeing by injecting radioactive material. Children are treated with bed rest and casting. Antibiotics are used for both adults and children, though sometimes the infection just has to run its natural course. With prevention, as I stated earlier, antibiotics are now used prophylactically, which is preventatively, in adults when undergoing spinal surgery. Prognosis is good, though it can take several months to several years for the pain to go away completely. That brings us to our final topic in this week's lecture material, and it's just a little intro to musculoskeletal neoplasms. Primary tumors will develop from or within tissue in a local area. They can be benign or malignant, and they can be in soft tissue or in bone. Malignant bone tumors have the ability to spread, and they often do so aggressively. When cancer spreads, it's called metastasizing. An osteosarcoma would appear in bones in an active growth epithelial plate. It is a rapidly growing and destructive tumor that results in pain, impaired range of motion, and inflammation. Rotationplasty is a surgery that removes the cancerous bone and uses an ankle to create a new joint. I've got a really cool video for you to watch on rotationplasty, but let's just finish up this last PowerPoint before you go. And yes, I did say that correctly. They are going to use the ankle to form a new knee joint. EWIGS is a malignant, non-osteogenic, which means it does not produce bone, primary tumor that can arise in bone or soft tissue. 80% of these tumors appear in people under 20. Risk factors are paternal smoking, exposure to pesticides, herbicides, fertilizers, and white ethnicity. It is a soft, viscous tumor that quickly outgrows its blood supply. There is local bone pain and swelling that is usually progressive. Multiple myeloma is a hematopoietic or blood-forming neoplasm or tumor involving bone marrow. Deep bone pain is a common symptom and the prognosis is poor. Most people die 1 to 3 years after diagnosis. Primary soft tissue tumors are benign and include things like a Baker's cyst, a lipoma, which is a fatty tumor. They usually don't cause any pain or problems unless they grow large enough to impede the function of another organ or if they impinge on nerves. Metastatic tumors are commonly spread to the lung, liver, and bone, and in that order. Cancer can spread through the bloodstream, lymphatic system, or spread to nearby tissues. Bone cancer is rarely the cause of death, but it brings on many complications like pain and pathologic fractures. And that does it for the musculoskeletal portion of our pathology class, except for when we talk about musculoskeletal neoplasms starting next week, which will be the final topic for your first exam. Don't forget, you've got one more really cool video to watch on rotationplasty. It's in your course content folder. Oh, before you guys go, did you hear about the guy that got hit in the head with the soda? He's lucky it was a soft drink. Ugh, bad puns. That's how I roll. Bye.